This is Conrad Fisher. I'm Associate Professor of Medicine, Physiology, and Pharmacology at Touro College of Medicine in New York City. This is the ethics section.
This section on autonomy will cover advanced directives, minors, and brain death. Autonomy is the very centerpiece of all medical ethics in the United States, the right to determine what to do with your own body. In this one sentence is the summary of all medical ethics and the ability to give consent, refuse procedures, and do what you wish with your own body. Every human being of adult years and sound mind. There's a lot more content in there than what you might think. First of all, you have to be an adult, you have to be over 18. Minors cannot give consent. And sound mind. Only a judge can determine competence, but a physician determines capacity to understand. So that small sentence may seem like just a few words, but there's a lot of content in there. Has to be an adult, and you have to have capacity. Every human being of adult years and sound mind has the right to determine what shall be done with his own body. What does that also mean? You can't make decisions for other people, even if it's in their best interests. Your own body, nobody else's. That means, except for a parent or a legal guardian, you cannot make a decision for anybody else's health care. And this is extremely important. Even if what you want to decide will help them, make them feel better, extend their life, and is good for them, you can't make that decision. And a surgeon who performs an operation without his patient's consent commits an assault for which he is liable in damages, except in cases of emergency. Also very important. Only the parent or legal guardian can make consent for a child. Yet, everything that's an emergency, consent is implied. How come a person doesn't have the right to commit suicide? Because being suicidal automatically in our culture means you are not of sound mind. So, except in case of emergency where the patient is unconscious and where it is necessary to operate before consent can be obtained. Justice Cardozo. This statement states the premise underlying half the ethics questions on Step 2 CK of USMLE. One is autonomy, the right to do what you want with your own body. Two, you have to be an adult. Three, the capacity to understand. If you understand these three things, this is actually one of the only sections where if you take these three things you see in front of you now, you can actually reason out almost every ethics question from these three principles. Patients have the sole right to determine what treatment they shall and shall not accept. Autonomy beats beneficence. Beneficence is not like a bad thing. It just it's a good thing. It's trying to do good things for other people. Listen, hey, I got some great food that you'd really like. Why don't you eat it? No, I don't want to eat it. But you love it. It's your favorite meal. No, I don't want to eat it. Okay, you don't eat it. It means that trying to help is not as important as following someone's wishes. It is very hard for people to understand, but that's the underlying premise. Patients have the right to refuse treatments that are good for them if they don't want them. A man has an ugly house. You offer to paint free in his favorite color. Everyone in the neighborhood agrees the house is ugly. And what you offer is clearly superior. He understands everything you're offering, including the clear benefit to him. The man still refuses. What do you do? And the answer is honor his wishes. No paint job. Now, this may seem like an exaggerated example to some of you, but it's totally not. Every time from now on that a question says my body, say his house, his car, and you'll be able to understand. You can't paste his house against his will. You can't do something. You can't get a psychiatric evaluation if the capacity is clear. No psych evaluations of a person's capacity to understand is clear. Asking the neighborhood council is like asking the ethics committee. There's no point in answering ethics committee when a person has capacity to understand. There's no point in getting a court order for consent if a person has capacity to understand. And there's no point in going to the spouse or children if, again, it's an adult with capacity. A adult with capacity beats all of these things. And choice G, wait until he's out of town, then paint his house. Again, it's not a silly example. This is the people who wait for someone to lose consciousness and then do the procedure when they've lost consciousness, such as wait for the person who's a Jehovah's Witness to lose consciousness, then transfuse them anyway. No bueno. Cost and benefit and the common good just aren't as important as the autonomy individuals have to do just what they want with their own property. A man comes to the emergency department after a motor vehicle accident and sustains a ruptured spleen. He's fully conscious. He understands he'll die without splenectomy, and he'll live if he has splenectomy. He refuses the repair and the blood transfusion. Entire family, including his brother, who's a healthcare proxy, and a document completed only a few weeks ago, clearly states everything should be done, including surgery. What do you do? And the answer is honor his wishes again. Now, the reason why this is important is because you can't wait until people lose consciousness, and it doesn't matter if he signed that document a few weeks ago. First of all, the healthcare proxy, the person, can't go against a person's stated wishes. Okay, he says right now, hi, I'm here, I'm awake, I'm alive, I don't want the repair. You can't say, but you just said recently that you didn't want everything. No, no, no. You've got to follow the last known wishes of the patient, even if they're verbal and even if they contradict the written proxy. It's kind of like saying, listen, Bob is going to vote for a certain presidential candidate. He just wrote it down. He wrote me in a letter. He wrote it 5 times. And then on his way to the polling station, he changed his mind and said he was voting for the other candidate. Well, you can't say to him, hey, Bob, you got to vote for the person you told me you were going to vote for last week. He changed his mind. So he's allowed to contradict his written proxy. You can't go against his wishes and wait until his conscience is lost and do the opposite of what he wants.
Advance directives tell caregivers the parameters of the care that the patient had wanted. They're a written document. The agent is the person who carries out the healthcare proxy. The advance directive is something that allows people to know precisely what the person wanted for themselves. The agent is a person. The advance directive is carried out by the agent. The agent is a person designated by the patient to carry out their wishes. The term agent is sometimes used interchangeably with a healthcare proxy, and the healthcare proxy is a written document outlining the parameters of care. The major problem with a proxy is the details of the care are often unclear, such as saying no heroic measures. That is not clear. It must be that it describes the level of care by the procedure. No chemotherapy, yes to transfusions. No dialysis, yes to pain medication. Then the advance directive is useful.
It is not helpful to just say no, quote, heroic measures. That's why there's a misunderstanding when people say, I thought a living will wasn't a legally valid document. No, a living will is a legally valid document, depending it says something that's clear. You see, if you had a will after you died for your property, and it said, hey, leave everything I have to people I care about. I mean, what does that mean? Who do you care about? Leave the important stuff to my brother. You see, that's what saying no heroic measures is like. You need something clear. I want $10,000 left to Bob. That's clear. Or if it says, I don't want intubation. To be useful, the document must specifically say no intubation, no CPR, no chemotherapy, no dialysis, no organ transplant. You can also specifically state your wishes about food and nutrition. There is nothing that says that a person can't put the proxy to say, I do not want artificial feeding. There's a common misunderstanding that says, oh, no, 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 you have to feed people. No, that's not correct. You feed people if they did not leave a clearly stated wish. If the person left a clearly stated wish that says, no nasogastric tube, no artificial feeding, that is clear. That is useful. If they don't state that, then yes, we do automatically feed people. The same way when you go to a restaurant, unless you say you don't want the glass of water or the breadsticks, they bring them to you. The proxy takes effect only when a patient has lost capacity to make decisions. Again, if you would think of it as your will for your property, if you left in your will your car to go to your sister, and then your sister shows up while you're alive and says, I'd like the car, please. You'd be like, wait a second, that's after I'm dead. No, it says right here you're leaving me the car. I know that sounds silly for you, but it's the same. Car, house, body. The order of decision making when it's an adult with capacity or healthcare proxy. Well, the adult with capacity supersedes everything else, and a healthcare proxy is extremely clear in terms of carrying out somebody's wishes. Ooh, let's spend a little time now looking at what happens when there is no capacity or there's no clear healthcare proxy agent. In the next in the order of decision making is the living will, a document outlining the patient's wishes. This is something that only takes effect if there is no capacity to understand decision making. Stating I never want dialysis is more valid than a family member or friend saying, hey, from what I know about him, he wouldn't want dialysis, or he never told me he wants dialysis. Very different. It's all about the documentation. A written living will with concrete statements such as I never want blood transfusion or chemotherapy is valid. Verbal things are valid as long as they can be documented by the people nearby. Verbal directions can be documented by persons clearly familiar with the patient's wishes. And the problem again becomes one of documentation. It's difficult for friends to document they knew the patient's wishes because most people don't walk around saying, hi, what do you want for lunch? And by the way, I never want methotrexate. If a case clearly states the friend knew and can prove that she knew the patient's wishes, then that's the plan of care that's followed. Now, next in the order of decision making would go to the family. Now, this is very fuzzy here, and it's always a problem if people are not in agreement. What is the order in which you should go to people? This one is the one where people make the most mistakes, because if the entire family shows up and says, we want our family member to have treatment X, and the proxy shows up, the proxy beats the entire family. The general order of decision making about going to a spouse or adult children or parents or siblings is exclusively for people who, one, don't have capacity to decide for themselves, two, don't have a clear healthcare proxy agent, three, never made a living will or advance directive, four, don't have people who are friends who clearly know and can document the person's stated wishes. But unlike life, in which things can be very fuzzy, USMLE Step 2 has to be clear. If the family is split, if the family can't agree, then the answer is ethics committee or court order. It may seem to you that how is it that anybody could have all the medical ethics issues in the world if Conrad Fisher right now in 10 minutes can give you this simple little handy dandy 6-step procedure? And that's because, first of all, when people have lost capacity, very few people have a living will that documents it, and the family is often split. Now, the reason that I can be clear is because we're studying for a standardized exam. And since it's a standardized exam, there has to actually be an answer. So when is the answer? Ethics committee. Ethics committee is the answer when the patient has lost capacity to make decisions, advance directive is either missing or unclear, and it's extremely important when we're trying to assign the term medical futility. Medical futility means when the patient or the proxy is asking for tests and treatments that seem to have no benefit. So ethics committee would be if the patient has lost capacity and they're brain dead, and the family says, no, I want you to continue the dialysis. Or the person is essentially pre-terminal, intubated, multi-organ failure on a ventilator, and the family says, no, I want you to do organ transplantation. That's when ethics committee can be very useful to back up the direct treatment of the patient. You notice that court order is dead last, right? That's not random. The way I've just outlined it for you in the order of adult with capacity, advance directive, living will, friends and family that have clear, documentable, stated wishes, then finally ethics committee, and dead last is court order, that's correct. It's dead last. There's no advance directive, the patient has no capacity, and most of all, the family is in disagreement. It's like a house being left equally to 4 children who can't agree on what to do with it. The caregivers want to withdraw care, and the ethics committee can't reach a conclusion. Court order is always last. Just like the medical questions where we say, well, when is this test the answer? When is this treatment the answer? Let's work backwards from the answer. Well, we can do the same thing with the ethics questions as well. When is psychiatric evaluation of the patient the answer? It is the answer when it is not clear if the patient has capacity. That's the main thing. Sometimes it's just a little fuzzy. The person's a little weird, they're a little difficult. People are allowed to be difficult and cantankerous. We don't have to all be charming. But that's a little bit different than saying the person doesn't understand the consequences of their medical decision making. Courts have allowed patients to refuse who had significant psychiatric histories. They allow patients to refuse medical treatments and procedures even though they might otherwise be considered incompetent for financial things. Financial competence has a higher standard than medical competence. In other words, we can say to you, I'm sorry, ma'am, your Alzheimer's is advanced to such a state that we just don't think that you should be managing your own money. You keep sending people checks over and over again. And then you can take the same person and she says, I just don't want that angiogram. I don't want that angiogram. I don't want the needle. And they'll say, okay, she doesn't want it. People have been allowed to refuse treatments even when people go, my doctor's an emissary of Satan, and I just don't want the pain of the procedure. They go, well, you may be somewhat crazy and you think your doctor's an emissary of Satan, and that's psychotic. However, you don't want the pain of the procedure? Okay, you don't have to have it. The standard allowing people to refuse is very low. Psychiatric evaluation is simply when it's not clear if the patient has capacity. The question must clearly states the patient has capacity. If the question clearly states that the patient has capacity, you don't need a psych evaluation if the person clearly has capacity. And if the person is clearly delirious or psychotic, then it's not necessary because they clearly don't have capacity. Your question has to be clear. That it's unclear. Minors, by definition, do not have decision-making capacity. They cannot consent to or refuse medical treatments. Only parents and legal guardians can consent and refuse therapy. Now, there's an exception, and these exceptions not for every child. They're an exception for people who are going to be adults soon, such as, say, a 15 or 16 or 17-year-old. The exceptions are contraception, prenatal care, substance abuse treatment, and STDs, including HIV/AIDS. These are partial emancipation issues. They are for when it is a teenager and we want to lower the threshold for a teenager to have access to contraception, prenatal care, and to get into substance abuse treatment to get their STDs treatment. So this is a partial emancipation. Now, this is not the same thing as calling it an emancipated minor. The term emancipated minor means one that is 17 years old that is fully emancipated because they are, one, in the military, two, outside the home, living outside the home, and self-supporting. At the age of 17, if you're living outside the home and self-supporting, you are emancipated for all decisions. That is a little fuzzy, but the ones listed in this slide, that you have a partial emancipation for issues of sex and substance abuse, this is clear. Minors in abortion does not have a clear answer. The states are split on the parental notification laws for abortion. Some states require it and some states don't. Well, how can you give an answer on a U.S. MLE, a national test, when 2/3 of states require parental notification and parental consent for abortion for a minor and 1/3 don't? Well, if they ask you, you have to give a sort of what might seem to some of you a namby-pamby unclear answer, such as tell the patient to notify their parents. And, we're not here to make up the rules, we're just here to explain them. All the other things that we said about minors, which is that you are partially emancipated for issues of sex, sexually transmitted diseases, prenatal care, and substance abuse, that's clear. You do not need parental consent to hand a 16-year-old contraception, period. But on this one about abortion and parental notification, there is no clear answer. On the subject of brain death, well, it depends on the culture. And in our culture, in our legal system, brain death equals death in our legal system. If you're brain dead, you do not need the consent of anybody to stop therapy such as mechanical ventilation or antibiotics. If a patient is brain dead, you do not have to have the family's consent to stop the ventilator. And this is a big deal because although you don't need a court order or ethics committee in order to stop treatment in someone who's brain dead, they aren't correct answers. Step 2 and step 3 for that matter will always want you to first discuss, educate, explain, confer before everything else. So this is an area where there's one of the few times I will say to you that if you have too much experience and know too much, you can get an answer wrong. For instance, if you know that a person is brain dead and that person is on a ventilator, you know that you have both the legal and ethical and moral right to walk up and turn that ventilator off. But if there is an answer there that says, explain what brain death means to the family, discuss it with them, make sure that they understand, that is the correct answer. If there is a person who is intubated and the mother walks up and says, continue the intubation, and the healthcare proxy walks in and says, I'm the proxy. My friend told me under no circumstance was he to remain on a ventilator. Under no circumstances was this to happen. You have the legal, moral, ethical, and medical right to pull the person off the ventilator. But if there is an answer that says, explain it to the mother, meet with the mother, confer, social work, get her to realize what things are, then that's going to be the right answer first. Just because you have the right to do something doesn't mean you shouldn't explain it first.